So that's 3 times. But anyways, once you're settled, what I'd like you to do is take a look at a person sitting on either side of you. And then remember back to the time when you were in medical school, sitting there, and then think about how big your class was. Your class was probably about 200. Multiply that times 2, and then imagine that those people are all gone, disappeared in a second. That is the number equivalent to physicians dying by suicide every year. And that number is probably underestimated. So we're here to engage in a real conversation with you, and that's what we want. We want a conversation. We're not going to be spewing stuff at you. So I'm Rita Manfredi from George Washington University, Washington, D.C.
I'm Sadia Akhtar from the Icahn School of Medicine at Mount Sinai in New York City.
I'm Amanda Deutsch from Thomas Jefferson University.
Jairam Pai from Morristown Medical Center in New Jersey.
And I'm Amanda Ritchie from LSU New Orleans.
All right, so before we get started, none of us have any disclosures to announce. But I did want to pause before we move forward to kind of acknowledge the difficult nature of the conversation we're going to be having today. At the end of this presentation, we're all going to include our contact information. We all genuinely welcome you reaching out to us at any time if you'd like to discuss any of the topics we go over. Furthermore, if you guys need to step out for yourselves at any time, please feel free to do so.
And really what we wanted to do today is just go ahead and identify stressors at the individual and system level that we have to deal with related to burnout. We all know that either within our own institutions or perhaps somebody that you know in your personal life may have died by suicide. And then obviously we know that that has a huge impact on all of us. And then lastly, we wanted to go into solution mode and really talk about the individual and system level solutions that we can sort of address for the risk of physician suicide.
So the next slide is a story. And this is Lori's story. Lori Weikenthal was a pioneer in emergency medicine, and unfortunately she died with cancer last year. But she had an unwavering quest for emergency physician wellness. So this is the story of her and her fiance. Oh, shoot.
Just the facts of another physician's suicide. We start with the facts because that's what we've been trained to do, to collect facts and data and then make educated decisions based upon those facts. So just the facts. It was May 5th, 1996. I was a PGY2 in an emergency medicine residency program. My fiance was also a resident at that program. He had the day off. I was working swing shift in the emergency department. I got off at 11:30, made it home by about midnight, and as I opened the door to our house, I knew that something was wrong. I could smell gas and vehicle exhaust. And as I hurried to the garage, I already kind of knew what I would find, but it was still a shock. I found my fiance dead on the ground of the garage. So what do you do in a situation like that? Well, you call 911, and they'll ask you, what's your emergency? And so I told them that I found my fiance dead in the garage, that I think he died of carbon monoxide asphyxiation. They offered to instruct me on how to do CPR. I told them I already knew how to do that, but didn't think it was correct in the situation. His face and lips were blue, and rigor mortis had already set in. Soon after that, I could hear the sound of sirens as police, fire, ambulance all arrived at our home. And then all of a sudden, my home became something else. Not just the scene of my fiance's death, but a crime scene. I was not allowed to stay there. I was not allowed to be with his body. I was asked to find someplace else to stay for the night. So I did what I thought was best, and I returned to my home away from home in the emergency department. One of the ambulance supervisors took me back to the hospital, where I found myself in an unusual position, in the quiet room. In the room we place our patients' families to break bad news. And it was still going to be my role to break bad news, but it was going to be over the phone, to my family, to Steve, my fiance's family, and to friends. Now remember, it's now about 1 or 1:30 in the morning, so this news is coming at the worst of times. Luckily, my family only lived about 2.5 hours away, and as soon as they got my call, they got in their car and drove to pick me up in the emergency department. We ended up in a hotel room somewhere around 5 o'clock in the morning, which was going to be just a place to stay because there was going to be no sleep that night. Following that fateful night, the next several days were a haze of his family arriving, of planning a funeral, of burying my fiance. And those are just the facts. But a life is so much more than just the facts. Steve was a brilliant medical care provider who cared about his colleagues and his patients. His loss deeply affected family, friends, the people he worked with, and the patients he cared for. So this talk about suicide and suicide in our physician population is not just about the facts. It's about lighting up the darkness and talking about these experiences with each other.
So I've been fortunate enough to have been on this panel for the past couple of years with Lori, and we wanted to keep her story up because every single time we listen to it, it still holds such an immense impact for all of us.
Thank you so much for sharing that. So what we do know is that there's limited data out there about suicides with physicians. We know that the last time the data was out there and really looked at was 2014, was the last time. And so a lot of this is extrapolated upon, but there are some true statistics we're going to talk about. And as Rita already said, 400 doctors die by suicide at least a year. We also know that about 10% of fourth-year students and interns consider suicide, and that physicians are at least 2 times more than their non-physician peers at risk. But in addition, and what's really important, especially as we're starting to get towards this time of the year where we have new interns and transitions, is we also know there's a high-risk period, and it's the first 3 months of being a trainee. During that period, the incidence of depression increases from 4% to over 25% in the first 3 months of intern year. And then interns' thoughts of death increase by 370%.
I think that's so staggering of a number to really understand. And, you know, even at LSU, we had one of our interns in one of the LSU residency programs die by suicide in the first 2 weeks of starting. They had just graduated. They'd barely gotten out of orientation, and they were dead within 2 weeks of starting, which is really startling and shocking and really hard to process.
So the risk is there, and it's real, as Mandy was saying. But often people are concerned whether talking about suicide is going to increase the likelihood that someone's going to attempt to take their life. So this fear has been driven by the media publicizing suicide, like suicide clusters or copycat suicides, especially after like a celebrity dies. But suicide prevention research clearly shows that the impact on suicide statistics is definitely determined by how the media presents this, how the media messages suicide. So you see two effects up there, the Werther effect and the Papageno effect. They're opposites. The Werther effect is the term given to suicide contagion after reading about suicide. So an example of this occurred in my hometown about 10 years ago. 7 young boys under the age of 18 at our high school died by suicide, one after the other, within a 2-year period. Now, the Papageno effect is the opposite, in which the suicide rates go down when suicide is publicized. And the name, this Papageno, comes from a character in Mozart's Magic Flute, and he is considering suicide for himself, but he's visited by 3 ladies who do something very wonderful. They listen to him, and then they suggest all these good reasons to live. So suicide prevention research has shown that stories of hope and discovery really go a long way in decreasing the suicide rate.
And I think it's also important to take this opportunity to really go over some sort of myths that are out there about physician suicide, and we just wanted to share a couple of thoughts here related to that. And as you can see here on the slide where it says women physicians die by suicide at a greater rate than women of the general population, I just wanted to get a sort of sense of the group here. How many of you think that that's true? And how many of you think that that's false? So wonderful to know that the group is right, that this is a true statement. And if we look at the research out there, definitely females in the general population will attempt suicide, but they are not successful because it seems that female physicians actually have more medical knowledge, and therefore they will try more lethal ways of dying by suicide. The most important thing also to mention is that the group that is at most risk of suicide is the male white physician who is in middle-age group. And so I think in general, I think we're all at risk, but it's important to know who is really at risk in the higher group.
All right. So next up, by a show of hands, this statement, physicians die by suicide more than any other occupation. Who here feels that statement is to be true? Few scattered hands, okay. False? Okay, yeah, majority has it. It is actually false.
Wait, guess who it is, though?
That's fair. So can anybody want to hazard a guess at? Okay.
No.
Anybody else? Okay, all right. So it's actually, every single year, it ends up being construction workers, believe it or not. So construction workers have the highest rates of suicide of any profession. If you stratify it by white-collar professionals, it actually varies from year to year. Some year it is veterinarians, other years it's dentists, and other years it's physicians. They are actually very close to one another.
Unfortunately, I've had several people in my life die by suicide. One of them was a friend of mine. He was studying sociology and a general manager at a grocery store to help put himself through school, and he displayed a lot of warning signs that, he was really kind of nearing the end of what he was able to tolerate, and, unfortunately, he died by suicide. And then the other friend of mine was actually working a few construction jobs before he was able to get into veterinary school, and he displayed no warning signs, none. Everyone thought he was his happy-go-lucky self, and he died by suicide as well. He was found in his car after being missing for 5 days. So I think this really elicits the point that it really doesn't matter what specialty, what work you're doing, what job you're doing. What matters is that we're all at risk for suicide, and we should all be checking on each other accordingly. The next question, of course, this is going to be near and dear to my heart as a resident. Residents are at high risk for suicide. Who thinks this is true? Who thinks this is false? Well, I would like to say, fortunately, this is actually false. So ACGME did an in-depth review from 2000 to 2014, and there's new data that's being processed from 2014 on that we have good data. So resident suicide death is actually below the rate of the general population. The highest risk, as we've already talked about, is within the first 3 months of internship. And then similar to the general population, the males make up the greater percentage. So suicide is the #1 cause of death in male residents and the #2 cause of death in female residents.
And I really am glad that Mandy brought up this because I will tell you that in my work, so I'm basically GME Wellbeing at Sinai, and what keeps me up at night is to worry about those residents and fellows that are not showing signs of anxiety, depression, that are just coming to work, putting a mask on their face and just basically plugging through. And I think it's really important for us to pay attention to those residents and fellows as well. Obviously, medical students coming to that play.
So, no surprise here. Who's at risk? In a nutshell, all of us. And there is reasons behind this of, if you want to go to the next one, of a theory called the Joyner theory of suicide. So I know we said we wouldn't talk too much at you, but this I did want to talk about of why this is. These overlapping factors really come together to have this cause. And the first one is thwarted belongingness. This is a sense of failure, a loss of a sense of isolation and loneliness. And I think we can all imagine, especially in that transition period, how this can be harder. Then there's the perceived burdensomeness, a sense of failure, a loss of direction and purpose, the system being harder and harder to go and fight against. And lastly, there's capacity, that we have the knowledge and access to actual lethal means to kill oneself, as well as overcoming the fear of death. So again, as you think about what our careers are all about, you can start to see how this would be really easy to put us at risk, that we are already, by the nature of our training, probably already always have at least one of these criteria against us, if not two, right? If you think about where you are in your career right now, back a few years when it's been harder, when it's felt more alone, maybe more of, does what you're doing matter? I remember as an intern always thinking that. I was like, my senior resident's doing the real doctoring. You could imagine how this easily comes together to put people at risk.
Definitely, I would say 2. Amanda says 1, maybe 2, but I definitely agree. All of us in here, including me, have thought, if I was going to kill myself, how would I do it? Would I do insulin? Would I do potassium? I think we've all thought about that if we're truly honest with ourselves. But the other thing is that burdensomeness that we're feeling now, especially after COVID, that the system is just weighing down on us, and nothing is a lot of fun anymore. It's sort of a hassle. And so I think we have 2 out of 3, and as long as we are very cognizant of that, we might have a fighting chance.
And I think we can do things to really prevent by boosting the belongingness, by having connections, reminding people that you see them when they're at shift with you, right? It goes a long way, so we have to work to prevent this.
Yeah.
So up on the screen here, we have a couple of resources, and the first one I wanted to highlight was 988. Has everybody here heard about 988? The federal government over the past couple of years has actually put $1 billion into creating this federally funded line. And similar to 911, you can call for any sort of mental health crisis you're facing. The website that is associated with that number is also available with plenty of resources. Those resources are available 24/7, and there are resources such as suicide prevention, counseling, and the interesting thing is if you call 988 and you seek help, they'll actually arrange follow-up calls for you as well. Also available is the National Suicide Prevention Hotline. There's a text line for people, and then for those that have had a family member, a friend, a loved one who have died by suicide, there's actually there's a website here for linking up people that have lost people.
Jay, what do we do, though, if there's no signs? I mean, we're really, really good at hiding it because we know all the language. We talk to patients, and we know the questions to ask. So if somebody asks us those questions, we know how to answer them. What do you think?
So I think the thing here is that waiting until someone seeks help in the career that we're in is oftentimes too late. I think you should really be having conversations prophylactically. In the same way we seek preventative medical care, there should be preventative psychiatric and mental health care available.
Yeah, and I've also heard that these prophylactic conversations may be uncomfortable. Like if you see somebody who's struggling, Joe, You know, it looks like you're having a rough time now. If you're ever thinking of doing anything that we shouldn't do, I want you to call me. You know, I just want you to pick up the phone first. That's sort of a weird thing to say, but that may help. And also something called the double tap. What's your name? May I? Jordan. Jordan, how you doing today?
Good, how are you?
Good. So, see how Jordan said good? I would say, maybe she said, yeah, I'm doing all right. Say, wait a minute, Jordan, and this is the double tap. Jordan, are you really doing okay? And you would be surprised. After that second, are you really doing okay? Sometimes you'd be surprised at what the answers are. And we've also known that, you know, anecdotally, there have been physicians who have been called by a member in their group, just out of the blue. Hey, can we get together? Do you want to do something? And that visit doesn't occur. But then a couple of days later, that person dies by suicide, the person that did the calling. And so if you ever get called by anyone who you don't expect to get called by to talk, that wants to talk with you, that may be a warning sign, and we just have to be aware of that, right?
One more thing I wanted to highlight before we move on from this slide. In terms of 988, there's also a website that you can go to. The website is available in multiple languages: Spanish, Taiwanese, Vietnamese, you name it, they probably have a translation. And it doesn't only have resources for your generalized mental health. They have really specific resources. Maybe it's maternal child, maybe it's LGBTQIA, maybe it's that you're in the labor force. There are so many resources that are tailored to whatever specific situation someone might be in, whether you're giving that email or that website to yourself, to your coworker, or to a patient. There's a lot available on there that is just not just one size fits all.
You may have heard me use the phrase die by suicide. Well, think about it. The way we traditionally talk about suicide separates it from all the other types of deaths that we treat in the ED. You know, there is no other committed death that we talk about, right? The word commit unconsciously makes us think this is an unchangeable sin or a crime. And those in the suicide prevention community actually think that preventing suicide is a very definite thing we can do. And suicide stems from a person's pain exceeding their ability to cope. So one of the best ways to reduce psychological pain is so simple. It doesn't take medicine. It's just to have the person express it, and then somebody needs to be there to listen. So a way to decrease the stigma is to show that one's open to conversation about suicidal ideation by using those words, die by suicide. So I challenge every single person in this room to take the words commit suicide out of your vocabulary starting today.
I think it also highlights an importance of the language that we use really, truly matters. Where, you know, a lot of times you say, oh, are you planning to hurt yourself? And the patient's like, no. Well, do you have a suicide plan? Oh, yeah. Because they're not planning to hurt themselves. What they're really wanting in the act of dying by suicide is for the pain to end. They are going to be out of pain by dying by suicide. So by asking them if they're going to hurt themselves, they're like, nope, I'm not. I'm finally going to be free of whatever pain they're dealing with. So I think listening to the language and you really being aware of the language that we're using is important as well.
And Mandy brings up a really, really good point, that if you were to ask somebody, you're one of your colleagues, do you want to hurt yourself, or do you think you're going to die by suicide? No, that's not the right question to ask a physician. The right question to ask a physician is, how hopeless do you feel right now? How much pain are you in? Do you want this pain to end? And will you do something to end this pain? So those are some of the questions that some of the research that's done on physician suicide has come up with.
I'm going to talk about Dr. Lorna Breen and the foundation. And if you don't know who Dr. Lorna Breen is or was, she was an emergency physician that died by suicide during COVID who worked in New York City. with Dr. Lorna Breen's death did come her brother-in-law and family creating the foundation, which has done incredible things. And one of those things really that they've done over the past few years is make some headway in making a difference for us to be able to talk about mental health. So they've actually, in multiple states now, and there's a map that shows this if you've ever looked at the website, and what we have up right now shows the most recent map, been able to go ahead and audit and change state licensing questions. And this is because her brother-in-law is a lawyer, and he's been working truly with legislation to go through and make sure these are being changed, so it no longer asks invasive questions about whether you've ever been treated for mental health, whether you are currently dealing with a mental illness, or you have that in your past. None of it matters in these states that have done this. And more importantly, what they've actually started to do most recently is work at the institutional level too. So your hospital itself that you might work at asks questions as well when you get hired. Or if you're finishing residency, you're finishing a fellowship, you need to know these things. But they are working right now to make sure that all this kind of questioning is taken out, that that invasive question is no longer there, so that we are free as emergency physicians to go ahead and get mental health care and be protected and seek help, just like everyone else.
And, go ahead.
And one of the great things is Stop the Stigma EM. Hopefully you've heard about this. If you've been to any of my talks today, you've probably already had to hear me talk about this. But this is one of SAEM's largest campaigns, and as you can see at the bottom of the screen, we have partnered with every emergency medicine society to go ahead and again, make a month-long campaign in October where we further the conversation after National Suicide Awareness Day in September, that we continue to talk about this to normalize us seeking mental health care no matter what, right? Our mental health goes up and down on any day, and especially in our jobs. So we have made this an immense push to normalize, to continue to push that we all seek health care, mental health care, just like we go to a dentist, be preventative, or even if it's not preventative, this is something we should all seek to do.
I noticed at my institution, we recently, unfortunately, had a death by suicide of a young male ophthalmology resident. And obviously, every one of my residents in emergency medicine knew the ophthalmology resident because he came to the emergency department. And he was so helpful to everybody. And he was this happy-go-lucky guy who was there one day and gone the next. I was very proud that GW did not just announce this as a resident death. They actually said this was a death by suicide. So I really see that as a positive in us sort of normalizing, not suicide, but normalizing being able to talk about it the way we would like to.
And I'd like to just say, if you want to join, you have actionable items you want to do about this, please join us. This is something we're continuing to do. It will be happening in October again.
Oh, and Mandy, you have some cards in front of you. What are those cards?
I do have cards. How did you know? So one of the projects that I worked on, along with Stop the Stigma, is creating these badge buddies. So these badge buddies, just a card you can hang off your badge. The quote that I think I'm the proudest of is that it says, "Support matters. You are never too new to support a colleague." And I think that really puts the onus, not only on ourselves, but on our colleagues, that, we're here for our patients, but we also need to be there for our colleagues and primarily for ourselves, because you can't pour from a cup that's empty, right? So there is some QR codes about how to handle a diffusing conversation, and then on the back there's some box breathing and some grounding techniques as well. So I have some cards here if anyone would like some when we're done the session.
And then we also wanted to share another resource. I think a lot of times we really want to get help, but we don't want to go to people in our own institution. And so back when COVID happened, they started this physician hotline, which really is a great resource. It's still in existence. It's from 8 a.m. till midnight, Monday through Friday. And essentially, you dial in, and there will be volunteer psychiatrists on the other end that will help you out and get you plugged into resources. So again, something that hopefully, we're sharing here today so that you can use that for your own self and for obviously your colleagues.
And other organizations are putting together peer-to-peer support programs on a national level that will be coming out. I know there are, like Cornell has a really robust program, and I know Stanford has one too. So that they're out there, and so we're getting the word out. So anybody else have anything before we? So we would like to show our contact information. Feel free to get in touch with us. But we'd really like to give a very special thanks to Lois Swisher, Megan McCreary, and especially Chris Doty, who gave us a lot of our information. Just really wonderful people. But we're wondering if you have any questions. And if you don't, we have some questions for you.
Yes.
How many calls a year does the national hotline get, like the 988 or the 1-800?
Of the 1-800 number?
Unfortunately, I don't think
We're
we
checking
have
right now.
that data, but I will say that between the national hotline, the 988 number, there's also the American Foundation for Suicide Prevention. They have an online screening tool also. We at Mount Sinai actually do use that service where the residents are able to 24/7 do their own internal screening, and we have seen an uptick after COVID happened. So we have definitely felt that we can use that even more from the residents and fellows perspective, but I see that there is information of 430,000.
That are routed towards 988. I didn't even look up the others,
That's
so I
awesome.
know 988 is still new. That's pretty impressive.
So
That's for the general public.
it's just a lot of calls for help. What are you guys doing out there? What are you doing at your institutions? Obviously, it's important if somebody dies by suicide, but anybody have any really innovative programs they're doing, opt-out, opt-in? Please.
Hi, I'm Kyra Reed. I'm one of the APDs at Indiana University. One thing that we have done from the get-go to normalize and kind of standardize the way we talk about mental health is from the very beginning during orientation. We have a retreat where we just talk about, like, here's how we view mental health. It's a preventative thing. This is, what we do to protect you and to also advocate for you. And so we do opt-out counseling. We saw an uptick we had 1 in 73 residents go to counseling before we did that, and now it's up to 65% of residents go to counseling. The main concern from our residents, though, was that they would have to disclose this. So to combat that fear, we've done 2 things. We've made it a curriculum. So this is part of your curriculum. Going into counseling is part of your curriculum. Peer support, we have peer support groups. So we have trained resident leaders, and there's a training program that we created that's been pretty successful, so that's part of it too. And so by saying it's part of your curriculum, that's part of your training. Just like you go to ATLS, just like you do all these things, this is on your calendar, this is what you should, this is what you should consider doing. And we've also, and I'm happy to share this too with you all, but I wrote a paragraph basically for anyone who's requesting credentialing at a certain facility if they ask inappropriate questions about mental health, which we all know that they're skirting around the law and rules about how they ask those questions. We as the PD team have a paragraph that basically says, we have this as part of our curriculum, this is all standardized, they all have access to counseling, so they probably, they have access to this, and you should consider removing this question or rewording it because we think that this stigmatizes. We kind of shame them for asking. Not kind of, we do. We do shame them. And I've used that paragraph so many times, even so far this year, for inappropriate questions. And we're keeping track of all that. But so I tell them up front, like in orientation, hey, we have this, and I show them the paragraph. And I say, you're protected from that standpoint, from these kind of questions, because we think it's not okay that they ask that. So I think that language and setting the stage from the beginning, the first day of residency, has helped kind of talk about it. And with the peer support, some of the training that we've given them, I'm hearing it in the ED now, like the verbiage that we use for peer support, like groups, not like different than one-on-one peer mentoring, but actually like peer support groups, like if you think about postpartum depression peer support or bereavement peer support, like how that's set up, we have that for residents. So I'm hearing that language now, trickle through the department. I think it's pretty cool. So that's what we've done, and I'm happy to share more if you like.
So, thank you so much. And honestly, I think it's so wonderful that you guys, like, you have a system already in place. When I was a resident, I remember very clearly during intern orientation, one of our attendings came in and he told us, like, one bit of advice for you guys, every single person here should already have a therapist and should get a therapist. And I remember as an intern, I was like, that's an odd thing to say the first week I'm here at school. I was like, or at residency. And then I kind of hit a low point my intern year. And I have always been really good about being able to handle my mental health by myself. And I got to the point where I didn't feel like I could do that anymore. And we had been given resources right at the beginning of orientation. So I dusted off that sheet that I had somewhere in a folder under my couch, and I picked it up and I started calling the numbers that were there. And I remember right now, one of those people had retired. Two of those people, the numbers didn't work. And then the last person, they were no longer taking on any patients. I was at a very supportive program, so I actually reached out to my APD, and he helped me get set up with mental health counseling, and he got me set up with a therapist pretty quickly. But I think it does lead to the point that, if you're at the point that you're in crisis and you're starting to reach for help, sometimes you're kind of reaching the point where it's almost too late. So I think it's really important to have something built in.
And then just to add, I think when we're talking about opt-in or opt-out mental health check-ins, a lot of people just get worried about the cost because they think that everyone should be seen by a psychiatrist. But at Mount Sinai, we have a couple of programs that do either opt-in or opt-out, and they use social workers that are their wellness advisors that are very trained to really understand and screen and know what to do if they designate that a person is in crisis. So I think that there are ways that programs can actually use the resources that are available to them already. They may not think that those are the traditional people that should be in those roles, but I think it's definitely something to be innovative about.
And I just wanted to say, because, I'm hearing some big academic institutions say what they're able to do. So if you're at a place that doesn't have that ability, or maybe those built-in systems or funding, there's even simple things we can think about doing, right? You can, on a conference day, say that the classes are going to split up and do a class kind of diffusing and just talk about it. It can be run by someone that either cares about wellness, or you can ask someone that's truly trained, whether it's a grief counselor, a social worker, a therapist, to come in and lead these, so that you at least, even if you can't get your individual residents to go seek care, can really lower that barrier. Because again, it's part of conference, you're breaking into your class, which already makes it easier to do because you're probably feeling more safe. And that way it's a lower cost, easier thing to come up with in the beginning when you're trying to do these things. That's actually an excellent thing, and just to piggyback on that, so our institution does something like that with positive psychology. We have something known as peers, which, I'm very sort of mixed feelings about this. It came out of the loss of a medical student at Mount Sinai, and one of her classmates really felt that they needed to do something for that class, and they came up with this whole process of peer support where they trained the residents in that program to become the facilitators of these process groups and really focus on the positive psychology curriculum.
And there were a couple of questions. Sir?
I'm wondering what has happened over the years, historically, say over the last 50 years or even 100 years. When I went through training, there were many attendings who would take, seems to me, pleasure in putting down residents and medical students. They would say, "You're the dumbest resident I've ever run across." or did you leave your head home today? Or how did they ever let you into medical school? And as a matter of fact, I went back to one of the reunions and I ran across one of the really old professors, who's close to 100 years of age. And he said, when you were a resident, we were able to give you guys a hard time. We can't do that nowadays. I miss it.
Oh, please.
So I'm wondering if you have any comments on that.
Yeah, I mean, is there anybody, like, whether you're at a supportive residency program or a less than supportive residency program, is there anybody here who can raise their hand and say that residency was easy and, like, it wasn't a difficult time? I mean, like, it's hard to be a resident even if people aren't hard on you. And honestly, I think it's wonderful to see that culture has shifted over time at a lot of our training programs, but I don't see the benefit in trial by fire any more than residency is already a trial by fire.
And I know we have another question, but I do also want to say, unfortunately, that still exists. At least when I'm only a few years out of my training, but those people still exist. So I hope it's fewer and fewer, and that those that are trainees in here are not coming across that, because it's just not the way to be. We can't have that toxic behavior anymore. We have to support each other to be able to continue this hard job that gets harder by the day.
And also remember that residents grow into attendings. Question.
Hi, thanks so much. My name is Patrick Ogersey from University of Utah, and just wanted to quickly say, I think we have an amazing resiliency center and program for, we have an opt-in, or I guess it'd be an opt-out program that all emergency residents have an appointment with a therapist on day one of their training, and then they can opt out if they want, but most of them at least go through the first experience. That being said, we've had our fair share, not necessarily in emergency medicine, but throughout the institution or other community hospitals, of death by suicide, loss, and just hearing you talk about like how maybe to word things, I have seen it responded to by various institutions in a number of different ways, but all of them seemed like fumbles to me. I don't think any of them have gotten it correct. And I'm just curious what you think from an institution is the right way to respond to such a tragedy.
Yeah, so I will tell you, unfortunately, we've dealt with a lot of loss, medical student, grad student, residents, faculty, and I actually am at like the table when we're deciding on how do we inform the rest of the institution. I will say that the most important thing to understand is to know that individual has a family and to really put the family in the center place, because sometimes when you're sitting with the deans, they're more interested in making sure that only a select number of people know what really happened. When just recently, unfortunately, we had a family who was saying that, no, we want everyone to know what exactly happened so that we can make it easier for others to talk about it. So at Sinai, we actually have a whole crisis protocol, which has language on emails that will go out if this happens. We also have like information on what to do at the memorial service, poems that you can use, like really down to the nitty-gritty. The other thing, I just want to give a shout out to the American Foundation for Suicide Prevention, because they have a whole crisis protocol that you can actually follow. And I think sharing information, you know, like I think that we in emergency medicine are a very small community, and if we know that there's a loss at an institution, I know that program directors will reach out to each other, that we will be there. One of the last comments I'll make is what we really understand is the circles of impact, to really first understand who are the people that are going to be impacted by that particular loss and who needs to know about it immediately and how. So whether it's like in person, email, or having a group discussion, it's a very sensitive situation for everybody involved. And last thing I'll say is that the leaders who are dealing with this also need to be focusing on their well-being as they go through this tragic loss.
And I'm glad you brought it up, because I love hearing the things Sinai do. I think it's just incredible. But I was at a med school that was losing either a PA or med student a year. They were dying by suicide. And so when I was a med student, I actually was like, what if we put in a medical student panel that we talked about the different mental illness we're all struggling with at different times, what we've gone through, what we might be doing right now, and we normalize it. And unfortunately, I was shut down. It was a hard no. It was not going to happen. And I remember feeling so just lost that we were not going to talk about things. And the numbers, I don't think, changed for a while, for a few years there. And it was just unfortunate, because the more we can talk and normalize, and I'm sure it's not a mistake that I went into wellness and wanted to talk about these things, I think the more we can do, the better. So just remembering to be open and to be mindful of how we can be helpful.
So, can I just say one thing first, and then we'll get your questions? And that is, 2 questions. I see them. This is all, we've talked about a lot of resident prevention, but like I said, residents grow up to attendings, and there's more attendings out there than residents. So how do we deal with identifying those attendings ahead of time, too, when they're supposed to be the strong ones that are taking care of us in our residency? If we have time to go over that, we will, but let's take our questions first. I think the back first and then the front.
Thank you, Leo.
Sorry, it was the front first and then the back, sorry.
I don't know the literature all that well on suicide and the effectiveness of therapies, but I believe I've heard that there's different effectiveness with therapy between male patients and female patients, and we see I believe your statistics were that male suicide is much higher in the physician population, and I'm just wondering if some of these interventions, it seems like we're not targeting based on sex or gender, and should that be a consideration given the state of difference between the sexes in these outcomes?
Why don't we get the second question also? So since we only have about 3 minutes
So
left.
while
and
we're
we
giving him the mic, I think that is why affinity groups like FemEM and whatever that's named at each place, like why that matters too, to at least start giving yourself a small group that you can have that peer support.
I'm Matt, a rural journalist from Australia. I'm wondering if in the US there's an appetite for addressing kind of the systemic and administrative upstream causes of the hopelessness and the isolation that Venn diagram pointed out. I guess if we see suicide as the fatal complication of a chronic disease, it's very easy to put the burden on the individual that's experiencing suicidality to say, well, they need resilience, they need to reach out for help, they need X, Y, and Z. But these aren't weak people. These are people who are in circumstances that are pretty bleak and unbearable. And I wonder if there's any appetite for addressing the disease rather than the individual experiencing it.
So we've been trying to address this from self to system for many years, and it's fallen on deaf ears, and this is the Rita Manfredi reason for it, and that's because there's such a financial bias that's on this, and so that's why the system is not fixed. God, you were gonna say something.
But yes, we are trying. Those of us that are up here are trying, but so are a lot of the people that I know are in the audience here and are not even here right now. We are trying to change the culture to be a supportive culture for well-being and wellness, and we are trying to slowly do that, which it is slow, unfortunately. Medicine is behind on making these changes compared to the business world, but I do appreciate your asking that.
To just go back and address the previous question that was asked about gender-specific and maybe, generational-specific mental health. I think, the highest risk of physician suicide right now is middle-aged white physicians. But at this point in time, if you go back to when they were trainees, they probably didn't have much access to mental health resources at that time. Personally, my hope is that the more programs that implement opt-out mental health resources, the more you're getting residents from the ground level up recognizing that it's okay to seek help and that there are systems in place that you should seek. And then once you go off to be an attending, you kind of stay plugged into those resources. And while the statistics might be what they are now, hopefully you do see a shift in those distributions as time progresses.
And just one thought for you to take with you when you leave. If you ask somebody if they're in a lot of pain and feeling hopeless and they're your colleague, and they turn to you and say yes, what are you going to say next? Well, I have an answer for you, something you can think about. And it was written about by Dr. Mark Goulston, Goulston. And this is his exact words. 7 words: hurt, afraid, angry, ashamed, alone, lonely, tired. Pick one and tell me about it. So I'll just say it again. 7 words: hurt, angry, afraid, ashamed, alone, lonely, tired. Pick one and start telling me about it. And that's some language you can actually use.
Wanted to thank everyone for being here. I know this isn't a positive topic to talk about, but it is important. And please reach out to us. You never have to do any of this work alone. We are here to work with you, partner with you. Please join Stop the Stigma EM, and let's continue to normalize this for everyone, no matter where they are in their career. Thank you.
Thank you.
Thank you, everybody.
At the end of the day, please have the conversations. You never know if your happy-go-lucky friend is the one who needs it. And please come pick up a badge, buddy.